Hi, I'm Adam Rosen and welcome back. In today's video, I'm going to talk to you about pain control. So pain is a normal expectation after surgery, especially after knee replacement. But many patients are concerned about pain and pain management, and patients are concerned about the use of narcotics. Now, what I do now is completely different from how I used to treat pain 20 years ago. So stay tuned and sit back, and we're going to talk pain control, and I'm going to go over all the things that we do in what we call a multimodal pain management protocol. So if you haven't already, please like and subscribe so viewers like you get updates when new videos like this come out. And if you haven't already, please check out my book, The Knee Book, The Guide to the Aging Knee. Now again, pain after surgery is unavoidable. And all patients have different pain thresholds. Even in one particular patient, biology can vary. I have had patients that have had one knee done and the pain was quite minimal and controlled. 3 months later, they have the other knee done, same surgery, same patient, but their pain is severe. Their body responded differently to the same surgical insult. So it can happen. And again, pain thresholds vary. I have seen patients take nothing but Tylenol and tell me that the pain wasn't that bad. And I have had patients that have had severe pain after knee replacement surgery, and I threw everything that we had at them trying to get their pain under control. Now, 20 years ago, the norm was patients would go to sleep with general anesthesia. They would have surgery. They would wake up, and basically we would pump them full of morphine. They usually had those pain machines, what's called a PCA. Patients were miserable. IV drugs work quickly, but they wear off quickly. So you would have pain relief, and then the pain would come back. And at the peak of pain relief, people would get nauseous and vomit, which is the worst thing that you want to do when you've just come out of surgery. So the pain control was a constant yo-yo. When we switched to pills, patients' pain control got better because those pills, although they take a little bit longer to kick in, they last for longer and they come on slower and wear off slower. They don't have the quick peak and valley that we see with IV drugs. But with all pain medication, patients get constipated. It's a normal risk factor from all pain medicines, IV or pills. And I had a number of patients that after knee replacement surgery in their recovery, due to a complication of the pain medicine, they developed severe constipation. They had a bowel perforation and had to have an emergency bowel surgery after their elective total knee replacement surgery. And it started me thinking that I needed to find an alternative and a different way of addressing people's pain after surgery, such as knee replacement. Now, all patients are different. I have had patients tell me that they do not want to use any narcotics whatsoever. And I have had patients that only want narcotics get angry that I don't give them more and fail to follow our multimodal pain protocol by using different drugs. So every patient experience is going to be different for the individual. And we can't treat everybody the same. So every single person over time gets an individualized pain protocol, but there's some basic guidelines that we like to follow. Number one, the goal is to be preemptive, the idea of blocking pain if we can before it actually occurs. And studies do show that the pain levels do not get as high if we use things like blocks and pain medication before the insult occurs, before the actual surgery occurs. The other goal is to use what we call a multimodal approach. It is using different medications, all of which work on different pain receptors, to work in combination to reduce the total pain, as opposed to using only one drug and using that one drug in excess, which can lead to a lot of complications. And the other part of that multimodal approach is the goal of limiting narcotics, and in some cases, not using any narcotics at all. So in these next few moments, I'm going to talk to you in more detail about how we treat patients with a multimodal pain protocol. The first thing is to let all patients have realistic expectations going into surgery. I tell all of my patients that knee replacement is one of the, if not the most painful operation that we do in orthopedics. I let them know that this is going to hurt. They're going to have pain, but I want them to think about it as opposed to the chronic pain that they've been living with, which is getting worse. This is a post-surgical pain, which is going to be getting better. The other important thing is that scale 0 to 10, which is not great. Don't ever expect your pain to be 0. We're not going to be able to give you enough medicine to make the pain 0, so there's going to be some level of pain. But the goal is controlled pain. This is pain that allows you to walk, to talk, to do therapy, to sleep. And we want to make sure that your pain is controlled so that you can do all of those things throughout the day. But at the end of the day, you're still going to have pain and discomfort. And again, every single patient is different. Now, we start all patients with preemptive analgesia. So this is medicine to control pain before the pain actually occurs. And this happens in a couple different ways. So at home, one of the things that you're taught before surgery is that you have to stop using anti-inflammatories or Nsaids. So things like ibuprofen and naproxen and other prescription medications like that, because they increase the risk of bleeding. And what I found over the years is that many patients were afraid to take anything for pain because they didn't want to make a mistake. And acetaminophen or Tylenol is safe to use. So I have patients follow the rule of 2s. They take 2 pills of the extra strength, each of which is 500, so 1,000 milligrams, 2 pills, twice a day, morning and evening, for the 2 days before surgery. Some people will even use it longer than that if they're having pain once they stop their anti-inflammatory. But we're getting a loading dose and hitting therapeutic levels before they even show up at the hospital. The other thing which I sometimes use is CBD. So I'll talk about that a little bit later. But CBD, which is THC free, is used by a lot of patients. Most studies show about 20% of patients in the US are now using CBD. I did a study and I actually had close to 50% of patients, and maybe it's a California thing, but a lot of patients are already using CBD. The studies are still coming out to really prove if it helps pain, sleep, anxiety, inflammation. But some preliminary data shows that it may help all of those things. So in patients that are interested in using it, I'll have them take 1 CBD tablet a day for the 7 days prior to surgery, again, as the preemptive at-home analgesia prior to knee replacement surgery. Now, at the time of surgery, there's a whole different type of preemptive anesthesia that we'll use to decrease your pain after surgery. So many patients, when you come in, will get a pre-op cocktail, and depending on your doctor, this cocktail may change. I'll typically give them a loading dose of acetaminophen if they didn't already take it at home that morning. And then we use an anti-inflammatory, typically Celebrex, because it has a lower risk of bleeding. Patients will also get sometimes a long-acting narcotic like OxyContin, which will last over 12 hours, but it's a low dose. And most patients get an anti-nausea medicine because it's common from pain medicine and anesthesia to develop nausea. So we give all of those patients the medicine an hour or 2 before the actual surgery. The other most important thing, which is used pretty much everywhere nowadays, is the idea of what's called a regional block. So this is actually injecting numbing medicine around the nerve in the upper thigh, which controls most of the pain fibers in the region of the knee. And it's shown that by blocking those nerve fibers before the surgery ever occurs, again, the pain levels never get as high as they would if we weren't using those nerve blocks. Now, there's some other things that are after the surgery, but before you wake up. Some patients will get what's called an intra-articular injection. So we'll use numbing medicine and inject it in and around the knee, again, to reduce pain by numbing those nerve fibers around your knee. And the other thing, which is really important but forgot about commonly, is attention to detail on how the soft tissues are handled. So one of the things that I always teach our young doctors is that how hard you pull or stretch the tissue may cause an inflammatory response, which can increase the pain. So it's all of these things that we're doing together. Pills, attention to detail during surgery, preemptive medications, and nerve blocks, all to control the pain that you will feel once you wake up from anesthesia and from surgery. Now, this next part, I'm going to talk about my postoperative pain protocol currently, and it's something that has changed over the years, and it's in detail, so it might be a little overwhelming to some people, but patients are really smart and savvy nowadays, and they know this information. So for most of my patients, and again, every patient is a little bit different, but the goal is a multimodal, different medications that work on different pain receptors, all to hit the pain receptors that can cause pain in general and trying to keep those medications at the lowest dose possible. So number one is acetaminophen, which is Tylenol. And we typically will do 1,000 milligrams 3 times a day for a week, and then 2 times a day for a week, and 1 time a day for a week. And if the pain is not that bad, they can wean off quicker. The other thing I'll typically use is Celebrex, which is an anti-inflammatory but has a lower risk of bleeding. And we'll use the 200 milligram dose twice a day for 3 days, which is the acute pain dosing, and then once a day for a month. And again, patients have the ability to get rid of it sooner if their pain is controlled. Now, for more severe pain, I'll give them a prescription for Oxy-IR. So this is Percocet, but without Tylenol. It's oxycodone. And we use a small dose and even have them break them in half. So they're taking basically 2.5 milligrams of oxycodone for severe breakthrough only. It is not a scheduled drug. It is only to be used when the pain is severe and out of control. And it's important because when you're using narcotics, they can cause constipation. So it's important to stay hydrated. It's also important to constantly keep moving and walking around to prevent constipation. Eat a high fiber diet. Now, there's some other things that are not drugs, but part of that multimodal pain protocol is icing, diligent icing, whether or not you use a bag of ice, frozen peas, or an ice machine. The patients that more frequently ice all report less pain, and clinically when I see them, their knee just looks less swollen and less red. Elevation and swelling control is extremely important. Everybody swells differently. If you swell a lot, you might need to elevate more. You might need compression stockings or wraps. If you don't swell a lot, it's okay to get up and move around more frequently, but swelling can cause pain and can inhibit physical therapy and range of motion. And that's the other part of this, is that patients that don't move their knee as a whole tend to have more pain, more problems, more at risk of scar tissue. So counterintuitive to what many patients might believe, and this is what I stress with my patients, is you have to move your knee. More frequent short range of motion sessions of physical therapy is better than one session followed by a long period of immobility. So different medications, icing and elevation, physical therapy and range of motion, those are the keys to decreasing your pain and keeping it at a manageable level. Now, the next thing I want to talk about, because I know some people are going to have questions about it, which is CBD. And again, I talked about it where studies show about 20% of Americans use a CBD product. And when I studied patients in my office, it was close to 50%. And again, it may be a California thing. So patients are using it. And what I found when I asked to see the products is many of them actually contain THC. So the person inadvertently may have been getting high when we want the CBD, which is derived from hemp, which is THC free. So there's one particular company that I recommend to my patients. It's a company called Corganics. They only sell through doctors' offices or hospitals. And there's a number of oncology centers, plastic surgery centers, and orthopedic centers around the US that are using this product because they test it for fungus, heavy metal, mold, which can be contaminants in some of the store-bought products. But most importantly for me, and for my patient's sake, is I know that they test it and make sure that it's THC free. Now, there's a lot of different protocols, and different surgeons around the country are using different protocols, but most of us have kind of narrowed it down to using the product, the pill, and we would take 1 pill a day for a week before surgery, and then 1 pill twice a day for a week after surgery, and then the last week you take just 1 pill a day, so it goes through almost the 30 pills that are in the bottle. They also have a cream form, and some patients have found use of the cream on the sides and behind the knee, but not on the incision. And they also use a dropper version, which is a liquid, which is a slightly higher concentration for acute pain. And we're going to be working on a study to really look at this and validate it, but my anecdotal experience has been a lot of patients have reported good success when they combine the CBD with the anti-inflammatories with the acetaminophen. So it may be something to talk to your surgeon about and seeing if it's something that would be okay or safe for you to use. Now, for some patients, once we throw all of the above at them, they're still in pain. So there are some other medications that we go to, usually not on an every patient basis, but in certain instances. So more frequently now, a lot of surgeons are using steroids in low-dose fashion after surgery that reduces both pain and inflammation. So it may be something that your surgeon may use. The other thing is a medicine called gabapentin or Neurontin, and that is a medication that has also been shown to decrease pain and symptoms and may be added to your multimodal pain protocol if the prior medications are not doing their job. Interestingly enough, sometimes an anti-anxiety medicine can help. So it's not that someone is not having pain or not that the pain is in their head, but patients that have very high levels of anxiety tend to hypersensitize their nervous system. And if we've maxed out all of the other medications, sometimes an anti-anxiety medicine lowers or reduces the anxiety, which in turn lowers or reduces the pain that the patient is feeling. And the other thing is many patients now are being given aspirin for DVT prevention or blood clot prevention after surgery. And there is a small anti-inflammatory component that comes from the aspirin as part of this multimodal approach. Now, there are a number of other things that you might try if you've maxed out all of the medications and you're still having pain or symptoms. So the idea of meditation or mindfulness-based programs, one of the most famous ones is what's called mindfulness-based stress reduction. John Kabat-Zinn designed this program back at University of Massachusetts, and it's available at a lot of places. It's an 8-week program, so it's not something to jump in after surgery, but something that you may take before surgery, and then you'll have those tools that you can use after surgery. But guided meditation may help, especially guided meditation with just the focus on the breath. Just sitting and placing your attention on the breath. And there's a number of apps that you can find online if you would like a more guided approach. Because the breath is something portable. We have it with us at all times. And even breath work can reduce pain and anxiety. So you can do what's called box breathing, where you increase or inhale for a count of 4, hold your breath for a count of 4, exhale for a count of 4, and then hold your breath again for a count of 4 and go through that cycle in that box. Some patients also like 3-7-8 breathing, and this is where you breathe in for 3, you hold for 7, and you exhale slowly for 8. And if that is too confusing, too many numbers, you can simply breathe in and exhale as slowly as possible. That stimulates our parasympathetic nervous system. The parasympathetic nervous system is the rest and digest system, and that allows your body to calm down simply by having that slow, controlled out breath. Now, music therapy can be helpful. A lot of people are now using binaural beats. There is a company that offers downloads where you can download binaural beats to use for pain and anxiety, and I'll put that link in the show notes. Patients have even gotten benefit from massage, especially lymphatic massage if you're dealing with swelling, because again, swelling can cause pain and inhibit range of motion. So finding someone, a spouse, a therapist, or a masseuse that can work on you and massage the leg, as long as they're not manipulating the scar. I've told my patients it's okay to get a massage of the leg after surgery. A lot of patients will try naturopathic options, so things like arnica and turmeric may have anti-inflammatory benefits that can reduce both pain and inflammation. Even over-the-counter medications like diclofenac gel, which is an anti-inflammatory, but you should check with your doctor to see if it's safer to use depending on what other medications they have you on for inflammation. And then some patients have even used acupuncture, which has been around for thousands of years, which can help reduce pain. One of the newer things people are using, and I don't know of any great studies that are double-blinded, but there's some anecdotal studies that show some benefit, is laser therapy, and a lot of laser centers are popping up. But again, talk to your surgeon before you go getting any specific treatment on or around your knee because of any risk of infection or complication. But all of those are things that you might add to this multimodal approach to help better keep your pain under control after knee replacement surgery. So again, after knee replacement surgery, and pretty much any surgery, pain is inevitable. Pain will occur. So have the proper mindset that you have chronic pain from a disease, and you've exhausted conservative care measures, and now you're going to have surgery, which even though it may cause pain, is a surgical pain that will get better and improve over time. Have a plan. Discuss this with your surgeon and your surgical team, and know what the plan is to control your pain, both before, during, and after. Know what to use for breakthrough pain. Have a treatment algorithm that you truly understand. And as pain improves, get off of unnecessary medication. Too often people continue medication long after they've needed it, and that has resulted in complications. So watch out for side effects, especially constipation, which is common with the use of narcotics. Understand and believe that you will get better over time. Therapy is key, but pain control to allow you to do the therapy is part of the post-operative protocol. I really wish you luck after your knee replacement. I hope that your pain is well controlled, and I wish you both a speedy and an uneventful recovery. Until next time, I'm Adam Rosen. Stay safe.